Hello, Overcomers, and welcome to this episode of Connect Over Coffee. I'm Runsi, the founder of Overcome, and today we are joined by a very special guest and a friend of Overcome, Dr. Erin Stevens. So Dr. Stevens is surgical oncology specialist at Prevea Health, and as she says, she believes in comprehensive, personalized, and patient-centric care, which includes nurse navigation, nutrition, social work, supportive care, physical therapy, medical and radiation oncology assistance, physician assistants, nurse practitioners, and access to clinical trials on a local, global, and national level. And we could not agree more with Dr. Stevens on that. So we have a lot to chat with her today about her passion and her focus on the patient and the overcomer, as well as understanding cognitive side effects from treatment and some other topics that we'll touch upon. So grab your favorite beverage. I have mine, and let's connect over. There we go. And let's connect over coffee with Dr. Stevens. And as I always say, please share this video far and wide with anyone who may benefit from all the pearls of wisdom, all the great insights she's about to share with us. So with that, a huge welcome to you, or welcome back to you, Dr. Stevens, to this episode of Connect Over Coffee. It is always our honor to have you with us.
Well, thank you again for inviting me back. I've enjoyed working with Overcome over these last, I think it's been almost 2 or 3 years now. So I think what you do as an organization to really bring people together about education and about community is so important for patients.
Thank you. We appreciate the kind words. So I have several questions, but let's talk about you first. So from your TEDx talk to taking that trip to Bolivia to teach life-saving techniques to other doctors, tell us what motivates you to bring better care and hopeful alternatives to the patients and our overcomers. And how do you use your words? And the reason why I'm asking this question, because the words are important to you, as you have mentioned on your TEDx talk. So how do you use your words and your language to shape positive thoughts in your patients?
Yeah, I think that it's a great thing. And yeah, words are something I'm really passionate about. I gave my TEDx talk in 2021 about ending the war on cancer, and really about the use of the war analogies in cancer and how that really sets our patients up to not be able to experience the full spectrum of emotions that go through their cancer journey. Because you've got those moments where, yeah, fighting is what you're thinking about, but you also have those moments where you're scared, or maybe you've accepted something that the others around you haven't, and you don't feel comfortable being able to talk about that because you're in an environment where people are like, oh, just keep going, or just keep fighting, or, oh, but it's another day, or sunny disposition. And there are some days we are all there. And then there are some days that even non-cancer patient, we just have a bad day, and we need to allow our cancer patients to experience that full spectrum of emotions as well. So that's something I'm really, really strive for with my patients, is that we're able to talk about all the different emotions that they might be experiencing, and when they might notice that in different times in their cancer treatments. Because I had the conversation yesterday with one of my ovarian cancer patients. She's just finished all of her treatments, and she's sitting at that point where she's not going to see us again for 3 months. And I said, you know what I see in a lot of my patients at this moment? I see them afraid. And they get home and they're like, I don't remember what happened. I don't even know what stage what happened over these last 6 months to 18 months? Like, what was this? And where do I fit now? Because we all know that you don't just snap your fingers at the end of treatment and are miraculously better again. You are forever changed by what you've gone through with your cancer treatments. And so addressing that with patients and talking to them about like that these emotional moments that you are going to have are things that other people also experience at different times, and that it is okay to experience that. It is okay to have some form maybe of survivor guilt. Like, why did I make it, but my friend Betty, who sat next to me for all these chemo treatments, why did it not work for her, but worked for me? Those are all things our patients experience, and we need to be able to give them that opportunity to feel those emotions, to talk about those emotions, and really sit with that hard. We're not going to be able to just fix that or smile that away sometimes. I absolutely love the Inside Out movies. I don't have children, but man, just teaching that sometimes we have to sit in the sadness, or sometimes anxiety driving our life is actually a good thing, and how all these different emotions communicate, and recognizing that that's part of the patient's journey. And then you mentioned my travels to Bolivia, and which is super interesting for language, because I've been going to Bolivia now for 5 years. I've been working at the ECO in Sucre with Solidarity Bridge and Puente de Solidaridad, and I'm teaching the GYN doctors there how to do laparoscopic surgery, which is a newer technology for them, so that they can help prevent cancer before it starts in a lot of cases, or that they're able to treat early cancers in a way where the patients can recover so much quicker. And that's been a great experience, but I am not a fluent Spanish speaker. So everything I do has to go through a translator. And so, but what is universal about surgery that is so amazing is the human body looks the same on the inside, whether I am here in Wisconsin or whether I am 24 hours away in Bolivia. And so there is a universal language we get to speak with surgery, that I very much get a lot of, I don't know, just comfort that that's what we get to do all the time.
That definitely speaks, to your passion for our overcomers. Thank you for all you do. So just going in deep into this a little bit. So you also said a fighting coping style is not associated with increased survival. This is a quote from your
So my TED Talk.
Yes. So tell us more about this. And in your opinion, what do you think, which style is most effective? I mean, there is no right answer, but just
Right.
your opinion, while embracing the journey of overcoming.
Yeah. I think it's that idea of saying just be positive, like that you need only positive thoughts, and that's what's going to make you live longer. And they've actually done studies and shown that no, that actually doesn't make a difference. Whether you are a pessimistic patient or an Eeyore, as I like to say, or a Tigger, who's going to bounce into my office every time for treatment, that's not going to change your overall survival. Okay. The biology of the tumor is ultimately what we are really working against. And again, I always worry with my Tiggers. I say this, I worry about their crash. I worry about how they're going to be, because they are constantly trying to be this positive person to everybody around them and maybe themselves too. And then they have those moments where they are scared, or where we have to have that hard conversation about we are approaching the end of what we have the ability to do. And now we have to talk about that transition to the next step, where we're going to really aggressively manage your symptoms, but start to transition to end of life. And if we are constantly just being positive, there's no positive about that for most people. Most people don't want to talk about that. But avoiding talking about the hard things doesn't make the hard things not happen. And so it's okay. And I tell my patients that, especially when you can see the struggle in their eyes, that it's okay if you don't feel positive today. Okay. We're going to have moments where we're going to have really great news, and we're going to have moments where we're going to say, okay, that all sucked. And we're going to sit in both of those moments together, and we're going to be a part of this team and this journey together, taking care of you through all of these steps. And that's what's important to me, that I can give them those moments that maybe they need, because maybe they need to be positive in front of their children or their loved ones, but maybe they need that moment to break down when it's just me and them, or my physician assistant and them, so that they can really be able to go back out into the world after that appointment, be like, okay, I sat there for that moment. I did what I needed to do. And now I can move back to what my people around me need to.
That's beautiful. Thank you so much. The next question I had is, you are a doctor in a community setting and doing wonders for the patients around you. So in terms of what you see, please tell us about the key differences and the challenges that you face, that you notice in patient care, and how you think we should overcome them.
Yeah, and that's great. So I practice in Green Bay, Wisconsin, and I take care of the rural population of the North Woods of Wisconsin and the Upper Peninsula. And prior to this, I practiced in Montana for 5 years. So I took care of the rural population in Montana, Wyoming, North Dakota, South Dakota, and Idaho. So and I trained, I think that's important to know, I trained in New York City. So I have experienced city care and also some of the difficulties in city care too. We might talk about, that, oh, well, that's 3 miles away, but that is 6 subways and a non-direct route for a cancer patient to not be able to travel to. Whereas in rural areas, we're often talking about a 4 or 5 hour drive after the Upper Peninsula of Michigan just got 26 inches of snow. So how are we going to be able to get to those places? I have loved taking care of a rural population, and I think it's really important. I think it's very different than what we see in the traditional academic centers. Academic centers often are dealing with inner city. They are sometimes being able to go out to the community and see these patients, but to be able to understand what happens in a rural community is very different than what happens in a city. I mean, I think we see this reflected in a lot of things, not just our healthcare, also our politics of what happens when we're in a place where there isn't a major hospital, that the hospital is served by maybe a family doctor, maybe a couple of nurse practitioners and PAs. They may only have 1 or 2 units of blood in their blood bank if a cervical cancer patient comes in bleeding, because it's not a big enough community to support all of the resources we need. That being said, the community in a lot of these places is different than what I ever experienced in the city. The way the communities will really rally around a patient to support them through treatments, with helping them get to treatments, with helping them get things they need at home, with meals and all of that, that part of rural care, I've loved seeing, because I think that's the kind of support we want to see everybody experience, is to know that you are a part of a community and that community rallies around you. But there's a lot of restrictions in rural. Like, we talk about telemedicine, yet there are large swaths of the Upper Peninsula and Northwoods where we don't have good cell service. I don't have good cell service at my house. Now, I am lucky. I am able to purchase technology and do that, but that doesn't mean that that's the priority of some of our rural patients. And I think, we often talk about, well, if we could just bring them all this magic we have in the academic places in the cities, that will fix everything. But that probably won't fix everything, because that probably isn't what they prioritize compared to what somebody in a city might prioritize. And so we really have to ask them what their priorities are and how we fit in their priorities, not how they fit our priorities.
So,
I'm going to
so
pause you for a quick second because that was my
yes,
pager.
no worries.
That is the downside of being the only GYN oncologist in the whole community, is that you never really have that moment to think like, yes, I have an hour to sit down and talk to somebody.
Thank you for doing this. We are really appreciative. So not a problem. I was just going to ask you that in terms of, you were talking about what their priorities are. So I was curious to know, when it comes to access to clinical trials, one of the things that we always think about or talk about, is how does the rural community respond to the clinical trials availability, that so many, as you said, so many new advances are happening, so many things are open. So what has been your experience in terms of their, interest in signing up for clinical trials?
I think it depends on what we're talking about in that situation. There are some clinical trials that really put the burden on the patient, where they have to travel, like a drug trial. They have to travel to the center that can give them the drug. Well, yes, but we also have clinical pharmacists that are administering chemo in these areas. So why can't we bring the drug to them? Why do we have to create hurdles to make the patient have to travel? Or if we are having the patient travel for this, why can't we financially support that in some way, shape, or form for that patient? not to incentivize them to be in the trial, but just so that we're not adding to the burden of the financial poverty we put patients into through cancer treatment. So I think sometimes it's being able to stay close to home. That's a priority for them. Being able to do the things where they live. Yesterday I had a farmer in, and she had had a complaint, probably for 9 months, 10 months. She's like, but, I mean, we had to cut all the hay. Like, we had to wait till the hay season was done, and she's like, I don't have time until everything's frozen in the ground to do these other things, because I've got to live in the cycle of what the weather allows. So talking to the patients about the priorities, I do think is going to make a big difference. I think trying to make it so that we can financially support them in that treatment. And then I think a lot of it also is explaining well. I think we spend a lot of time not trying to put these consent forms into fourth grade education levels, but they're 12 pages long. And yes, we've got to disclose all of the things that could possibly happen, but that's going to be overwhelming even to an educated person. And so when you're trying to talk to someone, not saying they're not educated, but trying to talk to somebody who has a different set of priorities, figuring out a way to do that in a shorter fashion might be helpful. One of the little trials that we're able to do a lot is one of our industry trials, where I tell patients, you've been diagnosed with a cancer, and all we need is a donation of some tubes of blood. And they're going to go off and they're going to try to find markers in the bloodstream. That's going to be that blood test for cancer that we all want. And I very rarely have patients not sign up for that type of trial, because that's what we all want. And so sometimes it's also, how do we explain this trial in a way that the patient understands? And that also means being careful with these phase 1 and 2 type trials, where there may not actually be a direct patient benefit, that you're advancing future science. And again, that might not be a priority for that patient in that situation.
And I have always remained, and this is a topic for another day, but just in mentioning, I have always been curious about this phase 1 and phase 2, as you were talking about, because it's experimental, as you said. And so adoption rates and, for the interest level for the patient to sign up for something like this, which may, to your point, which may advance science, but may not be ultimately beneficial to the patient, that makes it a little bit tricky for. Yes.
Yeah. But I mean, I think underneath all of the stuff that we do, the design of the phase 1 trials, the talking to our patients about participating in trials, is the hope that what we are going to find is something better.
Sure.
And there's always that underlying hope for the patient that maybe it's going to help me.
Yeah.
Even if what we say to them is that this isn't designed to help you, this is designed for us to understand if this drug is toxic or not. We're always going to have that little glimmer of hope of maybe this is going to help me. And I remember talking to one of my senior medical oncologists about that, because I, got frustrated for a long time that we didn't see many advances in ovarian cancer. And now I feel like in the last 5 years, we've had an explosion of them. But for so long, it was like, we just have carbotaxol. We just have carbotaxol. We talked about PARP inhibitors as an up and coming thing. And it took about 7 years before I could prescribe one. He's like, yeah, but he goes, Erin, I remember when we would give drugs and nothing worked. And so I never know if it's this next drug that's the one that's going to work, because I've seen it happen. And so it's a totally different perspective change from some of our older colleagues who really saw what it was like when we had ineffective treatments. And now we have so many treatment options that work for small percentages of patients, but they work really well for those patients. And so it becomes how can we better figure out who gets what drug, as opposed to just treating everybody the same?
Exactly. Thank you. So we are going to focus now on a little bit on the side effects of treatment, right? And so, in terms of the longer term side effects of treatment, what do you see most in your patients, and what realities you think should our overcomers know of and expect when starting treatment uh, for recurrence, particularly both insensitive as well as the resistant ovarian cancers?
Sure. I think really enjoyed giving that talk at the last session about the cognitive effects of chemotherapy and kind of those things of what to expect. Because we certainly all know our patients will complain of neuropathy. I think that was really the first thing as we got patients with ovarian cancer to live longer and longer. The first thing that patients started telling us, no, but this is not acceptable. Like, this is not acceptable to live like this. Like, thanks for getting me this far, but I want better than this. How
Mhm.
can we make this less? And so it was patients and those patient-reported outcomes that drove us to change the way we administer Taxol and to do dose reductions in ways we didn't before, so that neuropathy would not be that long-term thing that patients complain the most about. But certainly, Taxol causes neuropathy, and so we try to pay more attention to it as we go. But that is often one of those side effects that we continue to study different things with, treatment fields and fuzzy socks or cold hands during treatment to try to make it better. And I love that we're exploring non-traditional ways to try to manage neuropathy as well. Chemo brain is real. Chemo brain, or the cognitive effects of chemotherapy, start during chemotherapy, and they continue, we know, for 6 months and often longer after treatments. And there's actual functional changes that are happening in our brains that we can see on MRI. So it's not all in your head. It's a real phenomenon that's happening. And when it comes to how to manage that, what I thought was really interesting and an area that we don't think about utilizing is that's what speech language pathologists are trained in. We think about them when we refer to them for swallowing studies, or, your elementary school child who's having problems with R's and
Yes.
TH's.
Mhm.
But speech language pathologists who work with patients who've had traumatic brain injuries to teach them those types of cognitive behavioral type things, speech language pathologists are actually a great resource for some of the therapies that we can use for chemo brain. And a lot of that's going to be, again, the internet is a wonderful thing. We've got lots of games and puzzles and things that you can do online that are actual cognitive training games. And they advertise them all now on, if you have any game app on your phone, like, this is a great puzzle for brain health, and this is a great puzzle for brain health. But that's a really actually a good thing. But it's something, I think the most frustrating part of any of this stuff is we want to do something and then move on from it.
Yeah.
We want to say, like, I did my puzzles, and so now I am better. But it's like brushing your teeth.
Right.
Brushed my teeth yesterday. I still have to brush them today. It is an everyday thing that we have to do. And that covers so many more things than just brushing our teeth and our brain health. But so many times it is something that we just have to incorporate into a practice every day. So neuropathy, chemo brain, and then as you're going into especially some of the newer treatments, some of our immunotherapies or some of our targeted therapies, we develop side effects that we, as the doctor, are so excited that you're experiencing. You've developed the rash associated with the TKI. And when you develop that rash, that means the drug works.
Oh,
We got to be better about explaining that to patients, because they come in with this rash and you're like, oh, this means the drug works. So they're like, yeah, this is not okay. Like, this is not, I don't want to be a red-faced person. Like, no, I can't, I didn't know that this was going to happen. And so the side effects of a lot of these newer drugs, because of the way they work with the immune system and the way they work with some of these different targeted pathways, it's a great question to ask your doctor. Like, okay, what are the side effects that you might celebrate that I might not like? And rashes being one of them, or, I've seen, I can't tell you that there's a study, but that patients who experience some of that morning sickness with PARP inhibitors to start on olaparib tend to be on it longer. And the patients who tolerate it real well tend to not be on it as long because of progression. I don't have a study to back that up, but I try to reassure the patients that if you're experiencing this, this is okay. And this is something that I've seen where maybe it means the drug's going to work, because we also need to offer some reassurance in that way as we're going through the different side effects. But I think our side effects of chemo, where we talk about like worrying about getting sick because your white count is low, or nausea and vomiting, we've been able to mitigate those side effects so well. So the side effects we are seeing with our newer drugs are different than the side effects we've seen before. I think the other one that I always like bringing to patients is when they're on bevacizumab, which is still a drug that by blocking those VEGF, it just can help prevent the cancer from stealing our nutrients that we're taking in, causes postnasal drip. And patients often don't remember to bring that up to their doctors because they think it's sinuses. They think, oh, I have allergies, I have a cold, I have this. I'm like, you getting the postnasal drip? And they're like, yeah. I'm like, yeah, that's the medicine we're giving you. There is nothing that's going to make that better. But that is totally the medicine. And they're like, oh, because they've tried all these over-the-counter things without telling us because they just think they have sinuses.
Right.
And that's another thing I always think is really important is patients are going to use the words that they know to describe the symptoms. So I'm going to look at that as postnasal drip for Avastin because I'm going to know that that's the side effect. Patients are going to think that PPE on your hands is the same as neuropathy because they have a sensation in their hands. And we've been talking to them about neuropathy for so long that, oh, that numbness, that tingling you feel in your hands is neuropathy. Well, PPE is a different process. It's going to cause a reddening and a blistering in your hands. But I still have patients come in being like, well, it's neuropathy. I'm like, no, it's different because it's a different process here. But it's what they know. It's the same with yeast infections and UTIs. It's the words we know, but I might think there's something else going on down there.
Right. So I've also, just talking about side effects, that the couple other things that are mentioned very frequently would be sleep disturbances, right? And then also those who go into surgical menopause, like younger women diagnosed with ovarian cancer, they struggle with it a lot. So, so what are your thoughts on those? And again, I know that there is no magic pill for either of these, but generally, what is your guidance for?
So first on sleep, one of the big things I talk to patients about is we try to figure out where their sleep is disrupted. Is it trouble falling asleep at night? Meaning, are you having racing thoughts? Can you not fall asleep? Is it wakening in the middle of the night and then not being able to fall back to sleep? Or is it early morning awakening where you're waking up and you don't want to, yet you wanted to sleep longer? We know that when you can't fall asleep at night with those racing thoughts. And I tell patients every time, I'm like, it sounds silly, but it works. So try it. Get a journal, empty your brain, set a timer for 1 or 2 minutes, empty your brain, and then physically close the book. And it works with our brain to say like, okay, I've emptied. And that helps a lot of patients go to sleep. And sometimes it's these little things where people are like, oh, that sounds so stupid. Just like gratitude lists sound really stupid, but they really work. Doing an actual physical activity like writing, and how writing is connected so well in our brain, and closing an object can help a lot with that falling asleep part. The middle of the night awakening with sleep, I often talk about whether or not that's hot flashes or night sweats. And then we have to talk about good, healthy sleep habits too. Do you have your phone at your bedside? Do you have a TV in your bed? Are you waking up in the middle of the night to pee, but then playing on your phone or doing something like that where you're going to re-engage your brain? Is the temperature in your room cold enough? We tend to like to sleep with lots of blankets, but some studies suggest that maybe we should be sleeping between 66 and 67 degrees with just a sheet. And I feel like most Americans are bundled under blankets. And so when you wake up in the middle of the night hot, you're throwing stuff off, but then, oh, I picked up my phone, and oh, maybe I'll get up and go to the bathroom. And so, we have to talk about just general healthy sleep habits as part of the important thing. Does your partner snore? Do you actually have sleep apnea that we need to examine? There are so many people with undiagnosed sleep apnea out there. I myself am probably one of them, that would benefit from getting that testing done to see if that's interfering with their sleep. Because, we can't fix a lot of the fatigue and the daytime tiredness and all of that stuff without fixing what we need, which is good quality sleep. And then the early morning awakening stuff often are signs of depression. And so sometimes when people can't sleep, we have to have that deeper conversation about, well, tell me the thoughts going on in your mind and tell me what's going on and how are you feeling about all of this? And if we are getting at some of that depression, to talk about how to treat that, both with behavioral health and cognitive behavioral therapies, and also sometimes medications in that regard. Now, surgical menopause, and our patients with early ovarian cancer or the patients who have had their risk reduction surgery to prevent ovarian cancer, surgical menopause is something that has gotten so much more attention, and what we are doing to patients, because again, the way the patients are reporting this to us and people starting to listen about it. Now, in the same token, it sucks. And sometimes that's the moment we have to start with. It sucks to be put into menopause and be pushed off that cliff earlier than you were supposed to. It sucks. It means your weight's going to change and your metabolism is going to change and your risk of heart disease is going to change and your bone health is going to change. And that is just the reality that we're going to live in. And that a lot of those cases, hormone replacement may not be something you're eligible for. I think it's important to talk to your doctors of, are you someone that can have hormone replacement? Because maybe you don't have an estrogen-driven ovarian cancer or gynecologic cancer. And is that an option? Did we, as we went into the whole, well, you need to get chemo, you need to do this, did we forget to take a step and look at that and say, are you a candidate for it? And if you're not, have we talked about the different medications and how they act? To try to mitigate some of those side effects. They're not going to make them go away. I mean, that we definitely know. Patients who go through surgical menopause are going to experience side effects at a much higher rate than people who have had natural menopause and then had surgery for their ovarian cancer. But we can work on the side effect that you are most affected by. So if that's sleep and hot flashes and night sweats, there's certainly going to be newer things that'll come out, I am sure, when it comes to metabolism with some of our newer medications to see if that helps. But some of this also is recognizing women have not been well studied for all of this. And so the hope with some of the initiatives, the National Institutes of Health and what Dr. Secord was a part of, to really drive that we need to research women so that we can get better treatments for these types of things. But until then, sitting in the moment that, yeah, this is really hard and I might not have the best treatment for you.
Dr. Stevens, thank you for mentioning all of this. I was just thinking while you were talking, is just having this discussion with patients who get, younger patients who get diagnosed and have their, surgery and such, that you will be facing these symptoms and there's not much we can do about it. I don't know how many of the doctors actually have these discussions with the patients, because sometimes it's also setting expectations. Sometimes that itself will make it a little more tolerable. It's because sometimes the patients are just thrown into this whole thing and they don't know what to expect, and they are struggling with the symptoms, but there's no one to talk to about this. But I just feel like you're saying, like having that conversation with the patient, that this is what you should expect after, and get back to us and we'll try to help you as much as possible, in itself can be very powerful. So thank you for mentioning that.
I think that's something that, and we spend a lot of time as patients go through treatment, is you have a symptom that's related to the treatment. The nausea, here's a pill. Here's a pill. Like, we have a ton of medications we give you because we know our drugs cause these side effects and that we can fix it with a pill. But some of this stuff we can't fix.
Right.
But we need our patients to know that they are not crazy in what they're experiencing, because that is absolutely something that women internalize. It's just me. I'm just crazy. Like it's my fault, or I'm not doing something right, or there's some wellness influencer that says that this is the magic something or other. And God, I wish we had the magic something or other. But sometimes it's sitting in the hard with the patient and just being like, this just sucks. It does. And I am sorry that it sucks so much.
And I
And
appreciate that so much. This candidness is so important because in one of our other OC360 Live, one of the doctors, he also mentioned exactly what you're saying, that because a patient talked about side effects, and he was like, because there are so many new treatments and the patients are living longer, and which is a good thing, but we really honestly don't know much about the side effects. We don't have all the answers. And
Mhm.
just being, because we are also walking this journey with the patient, as the patient is walking this journey now from 1 year to 2 years to 10 years, 20 years, we have never seen these things before. So that in itself was so powerful for him to mention and to share that we are all doing this in this journey together and learning from one another as we go. So that's so important. Thank
Absolutely.
you. Um, so I read that your top areas of expertise also include that the MMT tumor, as we call
Yep.
it, and the endometrial sarcoma. And but we hardly ever hear of these kinds of tumors. And so, tell us a little bit about what these types of cancer, ovarian cancers, are, and what therapies, if any, are currently available, like promising, and any guidance that you may have for such patients.
Sure. So the mixed malignant Müllerian tumor, or carcinosarcoma, it's a super interesting tumor. It occurs in the uterus and in the ovaries. And for a long time, we actually thought it was two different cancers, like a carcinoma component and a sarcoma, a muscle tumor component. And we thought it was a tumor that kind of collided. And then what we realized is it's actually a cancer cell, carcinoma, that de-differentiates into this muscle cancer as well. So it's a very interesting in how the cells themselves mutate and change to make this type of cancer. It's always considered a more aggressive type of cancer. And aggressive is a word that I've been thinking about how to use, because we talk about it in medicine as an aggressive type of cancer in how it might mutate or how it might change or how the cell might behave. And I think patients hear aggressive and they think it's something that is going to kill them tomorrow. And so I think, again, I think we need to somehow figure out how to expand our vocabulary there. But carcinosarcomas, both for the uterus and the ovary, are part of a new clinical trial, the GY-026 trial that's run by Britt Erickson out of Minnesota, that's looking at some of the molecular mutations we'll see. One of them is called HER2, and we hear about that a lot with breast cancer, and we're starting to see in some of the gynecologic cancers that might be a tumor that we can treat with the trastuzumab, the thing Herceptin that we use in the breast, but also some newer drugs like Enhertu. And so this is one of those trials that newly diagnosed using carbotaxol with Herceptin or Herceptin-like medication to see whether or not that's going to improve survival. And that's an all-comers trial, meaning stage 1 to stage 4. So that's great because sometimes we restrict things to early stage or later stage. And this is putting all of those patients together, and then we can separate them out as we go. Did we see the effect in the advanced stages, or did we see a bigger effect in the early stages instead of shortchanging our early stage patients that we caught early? And so we just give them the old stuff that we've had, being able to look at all of them together. So that's one of them. I think one of the things I've loved is the NCCN guidelines that we use have broken out ovarian cancer so much more. It used to just be you had ovarian cancer and there was one pathway, and now we really are breaking it down by histologic characteristics, looking at carcinosarcoma or clear cell separately from typical serous, looking at high grade versus low grade serous separately in those algorithms. And then I fully expect we're going to start to see mutations start populating into this, that if you have a HER2 positive, or if you have a P53 mutation, or if you have, a RAS or RAF mutation, that's going to start to become a part of our algorithms. We're not there yet, and that's frustrating, but we're not there in frontline. We're getting better at it, in that recurrent setting where we feel a little more comfortable about saying, well, let's try this, because you don't want to say, let's try this to a patient when you know you have a drug that works 90% of the time, and then find out that we tried a drug that turns out it only works about 20% of the time. So that's dangerous to do in the front end, and that's why we struggle so much with new frontline treatments. But that's why we're getting better at those later treatments. And then endometrial stromal sarcoma is a rare muscle tumor of the uterus itself. The reason I get some publicity on that one is I had a patient who had an endometrial stromal sarcoma in her uterus that was resected thinking it was going to be a fibroid, and it ended up not being a fibroid, but she did not want to have standard of care with her hysterectomy at that time and wanted to go on and have children, and successfully had 2 children and was on the Today Show as part of that. And now is we've completed she's completed her family, and we've completed that aspect of her thing. So it was just, we talked about her being a 1 in a million, and that's truly what she was in that situation. But that part of that was the patient-centered care. This was something that was her priority. And she also understood, like, we're going to tell you that this is what we need to do. But if you don't want to do that, we are making up what we are going to do, and we don't know what's going to happen. And she was willing to accept that kind of risk there. And I think it changes as she gets older in the process too. So,
yeah. While you were talking about all these tests that we need to do, there was a curious thing that popped in my head is, you are in a community setting, and oftentimes we hear that not all of these tests are available to the patients or provided to the patients, or even the categorization of the cancer itself is not always told to the patient. It's always like, okay, you have ovarian cancer, but not differentiating it to what type, So while you were talking about it, I was thinking that I know you do that because it's very obvious, but what do you see typically in a community setting in terms of this information dissemination of, what kind of cancer do you have? What are the treatment, modalities? What tests do you need to do? How often is that happening in a community?
Yeah, I think some of it's always an interesting discussion because it's always different based on different patients. Compared to an academic center, I am going to have very few patients, but I still have some that come into my office and say, I have done a PubMed search and I have looked up on clinicaltrials.gov, and I think that I am eligible for X and I want to pursue X. I'm going to have most patients come in, and sometimes I have to have a conversation about what the ovary is. And so we might be taking this on a little by little process. And it might be a little more broad categorizations. It might be you have the typical type of ovarian cancer. That's serous, but all I need you to remember, it's the typical type.
Yeah.
And so that way they can take that in. And especially as we get into staging, which gets more complicated with the molecular stuff, does the nuance of being a stage 3C, 2, 1B, N5, or you're stage 3, because that's what a general person knows. They know those big staging categories. And then can we, as they've gotten through treatment, build a little bit on that patient's education level about their own disease as we go through. That being said, we need to do the right things for the patient, regardless of what they understand. So if that means that every patient, we need to be testing them for an HRD mutation with ovarian cancer in that upfront setting, especially as we change how PARP inhibitors are incorporated, then that test needs to be provided. And we need to explain that we're testing your tumor itself to see if it has mistakes in it, and be able to explain and run those tests. But yeah, some of it is access to those. Like, luckily, a lot of those companies like Foundation One or Tempus are willing to work with people, and a lot of the community medical oncologists utilize these. I mean, the community medical and GYN and radiation oncologists, we go to the same conferences, we read the same journals, we stay on top of all of this stuff as well. It just may mean, and I mean, heck, it happens in a lot of the academic centers too. We have to take your tumor and we've got to send it somewhere.
Yeah.
And it's got to be processed and it's got to be tested. And we've got to get that information back before we can make these next steps and decisions. And I think that waiting for that is hard, but I think that waiting happens at all the places because some of these
Right.
tests take time
Exactly.
just to run. And that becomes part of that building process for a patient.
Absolutely. Thank you. So we talked about cognitive, we were talking about the side effects. And so I was curious to ask you that if you had to give 5 tips to our overcomers in how they, to overcome these kinds of cognitive treatments, what would that be? And what are some of the services you think that are available outside of institutions, which are, institution agnostic, that the overcomers may sign up for?
Sure. So one thing I think would be that those puzzle games and stuff like that are worthwhile to do, to build some time into your day to be able to do those games. And you can go online and you can search for some of the more formal ones in cognitive rehab type stuff for traumatic brain injury. I think that would be the other thing, thinking out of the box and asking your doctors, hey, do we have anything at our institution for people who have had brain injuries, or the neuroscience team? Can I ask them some questions? Because you might find there that they're in an organization where they've been touched by cancer and they've never thought about using their skills in the cancer setting. And so thinking outside of the box. So traditional puzzles, talking to people in the traumatic brain injury department, doing compensatory treatments is really important. So that is prioritizing your day, doing your stuff, when you have the most energy in the day. And isn't it fun that we have all these electronic devices that will now tell us that whether it's a ring or an app on your phone that, based on how you slept last night, your most productive time today is between 10:15 and 11:50. We'll use that information, but keeping a list, keeping a calendar, not trying to remember everything, being able to do one task at a time and stop the multitasking, that's really important in some of those behavioral treatments. And then things like movement therapy with Tai Chi has been shown to benefit our cognitive changes that happen after doing meditation or attention restorative therapy, really being out in nature. Those are things that help. And sometimes, again, we're looking for well, why isn't it a magic pill? Sometimes it is as simple as going for a walk in the woods without your phone.
Exactly.
And taking 10 minutes to do that, to allow yourself to reset, to unplug, to get back to, who we are as humans, that can help with that. So
And you said something earlier in the conversation that I very much resonated with. You said that when we give guidance which sounds simple, people think it's so stupid, it's ineffective, right? But I totally agree with you that simple things like these work so well for majority, like be it cancer or non-cancer, just sunlight during the day, right? I mean, I listened to the Huberman podcast, and so he's big into the light thing, and so it's light therapy and just get out in the sun and just soak in that nature, walk in the woods for like 10 minutes. I do that personally. Like each night I go out on a walk for 20 minutes. And I cannot tell you how much it refreshes me after the whole day. And it's become my routine. I've done it like 7 days. Then the 8th day, it's just clockwork, right? I mean, I'm stepping out because it's 8 p.m. So, and it really does wonders to your stress levels, your overall health, your mental, disposition. So simple things. And thank you for mentioning all this, because I feel they're very important, but it's mostly like, oh no, it sounds stupid, it cannot be true, but it really is true. So
right. And it's that brushing your teeth analogy, because doing some of these things that I've incorporated into my own life,
yes,
where I poo-pooed them for a long time too. Like, what do you mean sitting down and writing what I'm grateful for 5 minutes every day is really going to change my disposition? It's going to change your disposition. It's
yes,
gonna. It's
agreed.
gonna. Okay, but you got to do it every day.
Yes,
You got to keep doing it.
absolutely.
And again, I think a lot of this is stuff we want it to fix. We want to say, like, I was in the sun today, so why am I not happy 5 days later? But I was in the sun last week. I took my vacation and I did the beach, and now I'm home. And why don't I still feel rested and rejuvenated? Well, because you still have to brush your teeth today. So you
Yes.
still have to get that sun, or you still have to do these things, and you're gonna have to do them every day.
Exactly. Thank you for emphasizing on that. And so I know that we have talked about this throughout this conversation that, your practice and your philosophy seem to be significantly patient-centric, which we so much appreciate and are, grateful for. So in terms of the realities, and you talked about this a little bit earlier also, in terms of the realities of the cancer diagnosis, right? I mean, there are good days, bad days, there are eventualities, there could be great outcomes, not so great outcomes. So how do you guide your patients or advise them in terms of embracing this journey that really, truly no one wants to take?
Yeah. I think one thing that's something I talk to all my patients about is really celebrating the wins. When we have a good scan, that deserves a celebration. And that's one of the things we'll talk about. Like, what are you going to do today because you got the good news? What are you going to, how are you going to celebrate this? How are you going to commemorate this? How do we celebrate the little things and the little wins as we go in this process? Because not every day is going to be that little win. So we've got to take it when we get it. And we talked a lot already about the really just having those open, honest conversations, about your emotional health and how you're feeling and what's going on and, what worries you. I think that's something I always try to incorporate in one of the conversations with patients is, well, what is worrying you, especially when we're in the recurrent setting? What are you worried about? Because I might be assuming they're worried about, dying, and they're worried about their cat
Yeah.
because their cat is their most important thing, and they don't know what's going to happen to their cat. And so don't ever assume what the patient is thinking. Ask them and then give them that time to talk about what they're experiencing. Sometimes we have to guide through that conversation, but to really find out what's important. And I think that's important to me because I love, like, when I have patients that maybe have an animal that there's near and dear to them, and they come in and they will always show me pictures, or get to know your patients, get to know your doctors and your physician assistants and nurse practitioners, because we're going to be part of this care journey as we go. I think one of the things I love about GYN oncology is the idea we take care of women through their treatment, and often that means till the end of their life, and what that looks like. And being able to have those hard conversations as we get closer to the end of their life, about what's important, about what things they want to do, about who they want to be with, where they want to be. Because for my entire career, I have found very few patients as we're in that transition phase that don't have some internal knowledge that it's happening.
Mm.
So I'm not telling them something they didn't know kind of in the core of their being. And when we can talk about that openly, I think is a beautiful thing for the patient. And then as they share that with their families, a wonderful educational process for us about how to die well. Because that is going to be a part of every single one of our lives, whether we're dying from cancer or heart disease or something sudden. And so being able to talk about that openly with patients and their families, and that's going to come with tears, and that's going to come with laughs, and that's going to come with every emotion. It's going to come with anger at times. And so being able to say, like, this is all okay. This is all okay. And this is all part of the journey.
And I had the same exact conversation with my own mother 3 days before she passed away. So I know the gravity of this, and I appreciate what you said, because none of us are going to get out of this alive, right? So
Nope.
it is going to happen to all of us in whichever form or fashion. So, but I do support that, having that conversation, which I had with my mother, my own mother. I mean, it was just so liberating for her and for me. I'll never forget that conversation. And, I know that it would be, I would have missed out on things if I did not have that conversation with her. So thank you for mentioning that. So, as we turn towards hope and progress in 2025, I cannot believe we are there already. What are the most promising treatment and surgical advances you envision for our overcomers that you would like to share?
So I think, so I'll start with the surgical stuff. Some of the surgical stuff that is starting to come out, where we are able to highlight the cancer cells we can't see during our big debulking surgeries through different technology, is really exciting. Now, we don't know yet that it's going to give us the benefit of making people live longer. We always have to weigh being able to do amazing advanced surgeries and having a patient recover from that amazing advanced surgery. And I think we saw that as we started using more neoadjuvant chemotherapy, is I can do a really successful big surgery, but if you never get to the chemo that you need as part of this treatment, then that surgery isn't a success.
Right.
And so, but being able to maybe see the stuff we can't see, is that going to make a big difference? Can we start doing this more as we are becoming more and more skilled? And really, GYN oncologists are leading the field in what we can do with robotics. Are we going to be able to start doing more and more of this in a way that patients can recover from quicker and quicker? Is that going to change where we're going? I think we'll start seeing some of that in the next year or two. I mean, we're already seeing some early studies with looking for these, for the microscopic stuff we can't see with different dyes. I think when it comes to treatments, I think some of the way the trials are designed right now with our combo match, where we're saying you have a mutation and here's a drug, and we're going to try to marry them together, is so much better than what we used to do. And so I think really, and it's allowed us to expand across tumors and drugs and stuff in a way we haven't done well. So I'm really excited about using trials in that way for patients. I'm also really excited about the antibody drug conjugates. We are seeing such cool advances with hooking up known drugs to a way to deliver them into the cell. I am constantly amazed by what my colleagues are willing to investigate at the lab level to watch that translate into something that I get to prescribe. Now, my biggest frustration that I'll always have as a community doc is when you've got access to it and you know we can change standard of care with a drug that is out there already, please don't wait till you publish it in a journal or tell us about it at a conference. Like, let's get that information out right away so that I can change my practice, so that my rural patients can get that same care that they'd get if they were at an academic center. I think we could really be better about releasing our data results in real time when we can change practice with drugs we already have. I think it's always hard with the newest and best ones, but when we're studying combinations of drugs that are already out there and we can change our practice, let's do that in real time. We're in a technology era.
Love that. Thank you so much. So I've asked you a lot of questions, Dr. Stevens. What have I not asked you that you would like to share?
What are your plans for 2025, and where are we going to be overcoming next year?
So, I mean, as far as our plan, like I always say, when anyone asks me that question, I wish our plan would be to, shut the doors forever.
Shut down and go to the beach.
Yes, because, we want a cure as much as fervently as you do. So, as far as our plans, it will continue, and we have published a book and this year, which
I'm so excited about that.
Yes, so lots of things to come, but But in terms of any question, any answers that you wanted to share that I have not asked you, I know I've asked you a lot of questions.
Yeah.
Is there anything that you would like to share?
I think one of the other things that I think as we are going to see things change in these next upcoming years, I think just a reminder that your doctors are in this with you. And that if there was a magic pill or a magic cure or something like that, that we really aren't keeping it from you, that like we care so much about wanting to see our patients do well and live a good life. Like I want to close the doors too. There is nothing I want more than not having to do what I do every day. I love what I do every day, but if there was not cancer, I would be really happy to be on a beach somewhere. So I think just reminding, as there's going to be so much more misinformation and disinformation, we're not hiding something from you. If it's something as simple as metformin that's going to work on a pathway, I'm happy to prescribe it. Like we're not going to hide old drugs from you if old drugs are working. We're not hiding something magic. I want that magic pill just as much as the next person. So we're in this together. But I think that's something that I don't want to see. I don't want to see go away as we head into these next years.
Thank you. And my last question, and you know this question because you have been with us before. What message of overcoming would you like to share with our audience?
Oh man, we've talked about so much today. We've stolen most of the things that I love to talk to my patients about. I think my message for overcoming this time around is really, about living life. I think that is, of all the things I want most for my patients, I don't think cancer is what we need to change how we live our lives or to understand what's important about life. But I think it really does put things into focus for us about what's important, about who's important, about who we want to surround ourselves with and what things we want to do. And I think the biggest message I can give to patients is do the things. Do the things, live the life, because that is what we're here for.
That is so beautiful and so wonderful. Thank you so much, Dr. Stevens. This was a lovely conversation. We covered so much. We covered science, we covered compassion, we covered patient journey. So this was fantastic. Thank you so very much for sharing your time. I know you're a busy doctor and taking care of so many patients. And overcomers, I know this was you would agree with me that this was an incredible conversation that we had with Dr. Stevens, so candid and so beautiful. So please share this far and wide with anyone who may benefit from all the wisdom and the insights that she shared with us today. And we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep inspiring and keep overcoming. Thank you and bye.